Hi guys, I'm Dr. Ryan Kaiser. I'm a consultant pediatric gastroenterologist practicing out of Kolkata. So today I'll just discuss this short case which we had dealt with recently. So this was a 7-year-old boy. So he was having fever for the first 3 days of the illness, and the fever disappeared, and then he started having jaundice and pale stools. This was accompanied with some abdominal distension 4 days before he presented with us. And along with that, he had very good respiratory distress. SATs were coming down to 89, 88% without oxygen. And there was a history of eating outside food, in fact. The child had pani puris. There was some event, some mela that he had gone to. Thankfully, the child did not have any signs of encephalopathy. He was well oriented. He was talking to us. Although the child did say that he thought he's still in his hometown, but that is because the parents did not tell him that. Anyway, so on examination, the child had a big liver. The margins were rounded. There was also shifting dullness, so he had some ascites. Thankfully, there was no splenomegaly. Because of the ascites, there was a slit-like umbilicus over here. And on the chest sounds, lower zones, both sides had decreased vesicular breath sounds, indicating a pleural effusion. So the child also had a mild pedal edema. So essentially speaking, the child was having jaundice, abdominal distension, and essentially anasarca. A very important history is that the child was not given any hepatotoxic drugs. He did not have any cola colored or black colored urine. There were no school issues, there were no academic issues, and there was no history of any sleep disturbances or any GI bleeds. So, taking that important history to rule out DILI, drug induced liver injury, and Wilson disease, as well as anything sensitive of a chronic liver disease. So coming to the labs, is he had a high bilirubin of 7.9, out of which direct fraction was 5.6, a very highly elevated transaminitis level with SGPT more than the SGOT, SGPT being in the 3000s, and albumin was also low, it was 2.5, and GGT of 80, alkaline phosphatase of 450, sodium was 142, and the potassium was 3.1. Thankfully, iron was not very highly elevated, it was only 1.2. Hemoglobin was 12, counts of 24,550 with a neutrophilic predominance, indicating some sort of infection had also happened. Uh, Platelet counts were 4.8 lakh. So, suspecting a viral hepatitis, we had sent the serologies, and that came out to be hepatitis A IgM positive. Now, usually in an acute viral hepatitis, kids will have a fever, and once the fever disappears, the immune reaction takes place, and there will be hepatitis and jaundice. Here, this child had a reappearance of the fever along with a tenderness of the abdomen. Now, just to rule out other causes of infectious hepatitis, we sent a scrub and leptospira IgM. That was negative. Viral test was also negative. And on the peripheral smear, there was no malarial parasite. Just for completion's sake, we wanted to rule out autoimmune hepatitis. So the ANA profile was also sent. That turned out to be negative. So because of the respiratory distress and pleural effusion, we had to insert an ICD on the right side because the right side had more pleural effusion compared to the left. And this was to alleviate his respiratory distress. We treated with antibiotics. We gave albumin transfusions because of the edema, the ascites, and pleural effusion. We also gave spironolactone and KCl corrections so as to correct the potassium. Uh, and of course, also deoxycholic acid was also given to improve the bile flow. We did an ascitic tap. 2100 cells were there, where a 45% PMN count and protein was also elevated. SAG was only one, was not very high, and the CBNAT was negative. For completion's sake, we sent the CBNAT also. So from the ascitic cell analysis, it seemed like there was concomitant spontaneous bacterial peritonitis that had also occurred in this child, and that was responsible for the tenderness of the abdomen and the fever. We did an ultrasound, and because there was like good going ascites, we wanted to rule out Chiari syndrome. So in the Dopplers, we checked for the IVC and hepatic veins. Both were normal. Portal vein was also normal. There was no reversal of portal flow, so there was no portal hypertension. Echo texture was also normal. Also, we just checked the gallbladder. The gallbladder had a lot of wall edema, and there was periportal cuffing as well, and which confirmed our suspicions. And thankfully, it was only a case of acute viral hepatitis. So the provisional diagnosis here was that of ascitic variant acute viral hepatitis with spontaneous bacterial peritonitis. It was a long course. Child had to be in hospital for 21 days, including a 3-day PICU stay. But thankfully, the child got better and he was discharged at the end. Talk about this case because around 20% of acute viral hepatitis cases in children will follow an atypical course. And out of this, 7% will have an ascitic variant. So they will have ascites, but this ascites will not be because of chronic liver disease or portal hypertension. Rather, it will be because of the hepatitis leading to hepatocyte dropout, that is, the hepatocytes start to die, and that leads to obstruction of the sinusoidal lumen. If you remember your anatomy, there are sinusoids that are running from the portal vein branch right up to the central vein branch, carrying all the nutrients, and some of the nutrients gets absorbed. Then you have byproducts being expelled into the sinusoid and then into the central vein. So that sinusoid, if it gets obstructed, that can also lead to ascites in ascitic variant acute viral hepatitis. Usually this resolves in a maximum of 8 weeks, and the treatment is simply giving albumin, giving spironolactone, making sure that the potassium is at the right level so as to prevent gut translocation, and of course salt restriction. Some important takeaway points for this case is that do not panic. If you're a pediatrician taking care of a child with a viral hepatitis and suddenly the child has an ascites, do not panic. Diligently rule out CLD and portal hypertension using ultrasound and of course history and clinical examination. Keep the potassium above 4 to prevent gut translocation and spontaneous bacterial peritonitis as this child had. Fever followed by jaundice indicates acute viral hepatitis, but fever present along with jaundice may indicate some other infectious causes of hepatitis like scrub typhus, typhoid, malaria, and leptospirosis. Thank you so much. See you again in the next one.